This is the story of two children. Both swallowed a button battery. Both reached a hospital. Both should have walked out of this alive and whole. Neither did. I'm Dr. What Happens, and these two cases changed how American emergency rooms treat battery ingestion forever. Case 1. A 19-month-old boy. He was fussy, running a low-grade fever, refusing food. His parents brought him in. The chest x-ray showed it immediately. A 20-millimeter lithium button battery lodged in his upper esophagus. Within 3 hours, doctors had him in the operating room. Endoscopic removal. Textbook execution. The battery came out clean. There was a black, charred ulcer on the esophageal wall, but no perforation, no hole. They started antibiotics, monitored him in the pediatric ICU, and by day 5, he was eating again. He went home stable. 11 days after the surgery, he was in his own bed. His parents heard a sound. They ran in. The boy was vomiting bright red arterial blood across the sheets in massive volumes, his small body convulsing in shock. He collapsed before the paramedics reached the house. He was pronounced dead during transport. The autopsy revealed what no one had seen. The battery had been removed 11 days earlier, yes, but the alkaline chemicals it left embedded deep in the tissue never stopped working. For 11 days, hydroxide ions kept dissolving the esophageal wall, millimeter by millimeter, in complete silence, until they reached the descending thoracic aorta, the largest artery running directly behind the esophagus. The burn punched through. An aortoesophageal fistula. The child bled out from his own aorta into his esophagus. Case 2. A 2-year-old boy. 5 days of progressively worsening symptoms. Hoarseness, raspy wheezing, a harsh barking cough. His parents took him to a primary clinic. The doctor heard the cough, examined him briefly, and made the most common diagnosis in pediatrics, viral croup. They sent him home with oral steroids. 2 days later, the boy was burning with fever, drooling because he could no longer swallow his own saliva, gasping for breath. His parents rushed him to a tertiary emergency room. The x-ray they should have done 5 days earlier finally happened. A 15-millimeter button battery, showing the classic double contour halo sign, lodged at the upper esophageal sphincter. It had been there for 7 days. When the surgeons opened him up for emergency rigid endoscopy, what they found wasn't a battery anymore. It was a mass of black pus and granulation tissue. The alkaline fluid had completely dissolved the front wall of his esophagus. The burn had eaten through the esophageal wall into the trachea, his windpipe, creating a massive tracheoesophageal fistula. Every breath he took mixed with every swallow he attempted. And worse, the chemical destruction had completely severed his right recurrent laryngeal nerve, the nerve that controls the vocal cord on that side. The boy survived. He went through multiple complex reconstructive surgeries, including a colonic interposition, where surgeons removed part of his large intestine and used it to rebuild his esophagus from scratch. But the nerve damage was permanent. His vocal cord stayed paralyzed. He could no longer protect his airway during swallowing. He could no longer speak normally. He could no longer eat by mouth. Today, that child is alive. He breathes through a tracheostomy, a permanent hole in his neck. He eats through a gastrostomy tube, a feeding tube inserted directly into his stomach, for the rest of his life. These two cases teach us 3 things that every parent, every clinician, and every emergency physician needs to remember. 1. Removed is not safe. After every battery extraction, the hydroxide already embedded in the tissue can keep dissolving for weeks. That child needs vinegar irrigation in the OR, follow-up imaging for a full month, and clear instructions to return immediately for any chest pain, vomiting blood, or coughing. 2. Croup does not last 5 days and get worse. Real viral croup peaks in 2 to 3 days and improves. Any child with worsening hoarseness, drooling, or refusing to swallow needs a chest x-ray before anyone says the word croup. 3. Time is tissue. Every hour a button battery sits in an esophagus, the damage accelerates. 2 hours to a burn, 4 to 6 hours to a hole. days to silent erosion into a major artery or airway. If you remember nothing else from this video, remember this. If your child swallowed a battery, go to the ER. Not urgent care, the ER. And if you ever bring a child in for a barking cough that has lasted more than 3 days, ask for the X-ray. Ask out loud. Next week, what 2 magnets do to a child's intestine? Subscribe to Dr. What Happens.